get started. Thank you all for joining us. Happy New Year to those that we haven't been in touch with for a while. I'm Adeline Clemenson. I'm the chair of We Are Champions. And this is our first meeting of the new year with Dr. David Teeple. And we are doing it Zoom for obvious reasons. If you've been listening to the news, you know that Arizona is one of the worst in the nation as far as COVID, and all the hospital beds are full. And so we are continuing with our Zoom mode. So we will have other lectures later in the year, and they probably will be by Zoom as well. So I'm going to go ahead and introduce Dr. Teeple. He is a native of Tucson. He graduated from South Point High School before attending the University of Arizona for his undergraduate degree. He earned his medical degree at Columbia University in New York. He completed his neurology residency at Barrow's Neurological Institute in Phoenix. And in 2009, he became director of the Tucson Medical Center Stroke Program. In 2010, he was appointed the department head of neurology. And he currently is an associate clinical professor at the U of A, and he is director of the transitional residency program for the Tucson Hospital's medical education program. So he is very well renowned locally, nationally, and statewide, and maybe internationally, I'm not sure. David, you can speak to that. I've known David for a long, long time. He treated my sister-in-law for many years, and he's an excellent clinician, and he's a specialist in Alzheimer's diseases, and that's what he's going to be talking to us today about. So I would appreciate it if you do have background noise that you mute. And David, you can tell us how you want the presentation to go, if you want to make the presentation and then take questions afterwards, or if you want people to raise their hand and do questions during the presentation. You dictate how you want that. So okay. You can go ahead and get started for us.
Okay, well, thank you very much for those kind words. And so I'll start by saying I think that we actually have one of the worst COVID rates in the entire world. Right, sad to say. And certainly we're feeling it here at TMC. And so, as Adeline was saying, I'm a neurologist. I would sort of say that my fortes tend to be stroke and epilepsy. But as a neurologist, I treat a tremendous amount of dementia and Alzheimer's. And so I'm happy to be talking to you guys about it. And I'm pretty flexible. So if folks ask me questions, I don't know that I'll be able to see anyone raising their hands. I only have 4 people on my screen to be able to actually see my slides. But I don't mind fielding questions as I go along. If it seems like it's too disruptive, maybe we'll stop and wait to the end, but we'll sort of play it by ear, and I'm happy to try to field things as we go along. And so with that in mind, and so now backing up a little bit, this group that I'm talking to, are we, this is a group of leaders in Tucson, healthcare and outside, is that accurate?
We Are Champions is an advocacy group, an affinity group of TMC. So we are advocates for TMC. We want to get the good word of TMC out into the community. We want to help people get educated on not only their own health, but health of their loved ones and health of our community. So we really are ambassadors and wanting just to get the good word about our community hospital out into the community more.
I love it. Okay. Okay. And so the last thing I'd sort of end up with then is, right, as a neurologist here at TMC, I mean, this is the hospital that my family goes to. This is where my mom and dad would go. This is where my mother-in-law, who just called me 10 minutes ago, will come when she's sick. And so I'm proud to be the stroke director here, and I think we've developed a really fantastic program. And people ask me all the time, why did I go into neurology? And the answer is, the brain is fascinating. I'm going to spend the rest of my life focusing on one organ. I couldn't imagine spending all my time thinking about anything other than the brain. As we learn about the brain, the more we learn, the more fascinating it is. but also the more complex the organ, becomes, right? The more we learn, the more we realize we don't know. And I think of all the areas of neurology, this fits dementia and Alzheimer's disease probably more appropriately than anything else. And so we'll jump in and just go through my set of slides here. I hope they're interesting to you. And certainly, again, I don't mind fielding questions as we go along. And let me get started. So first of all, just defining dementia. Okay, dementia is really any condition that you develop over time, that you acquire, that interferes with your cognitive function. And cognitive function is a pretty broad area, right? That can involve your short-term memory. It can involve your ability to judge things. It can involve your speech. It can involve your ability to do complex tasks. Lots of different things fall under the realm of cognition, but any condition that causes you to essentially impair your ability to function either in daily life or at work. There's a condition before dementia that people talk about a lot called MCI, or mild cognitive impairment. And that's where we begin to see some cognitive issues, but they don't reach the level of really impairing the person in their social or occupational activities. You could, and the question often I'll ask is, in someone with dementia, could you leave them at home for a week and could they function by themselves? And sometimes there are non-cognitive issues. Oh, well, they broke their hip and they can't walk. So no, I couldn't leave them at home. But if the reason that they couldn't be left at home is because of cognitive issues, then that does then run into the realm of dementia. Whereas MCI patients, they can function. There's just a change from what their baseline was. There are lots of things that can cause dementia, but the neurodegenerative processes are the ones that we focus on in neurology. And so the notion here being a neurodegenerative process, some type of process that's progressive and ongoing over time, that's going to get worse and worse and worse if you don't do something about it. And that includes Alzheimer's disease. There's something called Lewy body dementia, vascular dementia, and frontotemporal dementia. And these differ a little bit in how they look. Lewy body dementia is a dementia that's associated with the accumulation of Lewy bodies. And these patients, they present differently than Alzheimer's patients. They often will present with some element of Parkinsonism, so rigidity, shuffling gait, arresting tremor. But it's, but the more prominent symptom isn't those movement disorder issues, which we see with Parkinson's. It's the memory issues, it's the cognitive issues. These tend to be very challenging patients because they're very sensitive to medications. Any perturbation from the baseline. Patients with Lewy body dementia have a propensity when their bodies are under stress or something new is introduced in to hallucinate, to sometimes become delusional about what's going on, often with symptoms of persecution and paranoia, which then make offering care hugely challenging for everybody. So Lewy body dementia patients, Parkinson's symptoms, and often frequent hallucinations and delusions. Vascular dementia, which is what you see here on this MRI, probably the second most common cause of dementia that we see. And this is just vascular disease, vascular injury, which can happen as discrete strokes, which is what the textbooks will teach you, but also as just a continuum of micro injury. These are often in patients with maybe not the best controlled risk factors like hypertension, diabetes, high cholesterol, weight, smoking, things like that we know contribute to vascular disease anywhere, heart or the brain. Interestingly, there seems to be a continuum of vascular disease and Alzheimer's, and that they're connected, although we don't really understand that well, but I'll bring that up at least to some degree later on in the talk. And then there's frontotemporal dementia. The frontotemporal dementias are among the more interesting and also frustratingly tragic diseases, but these are dementias that are associated, they actually used to be called something called Pick's disease. And what we see is injury specifically to the frontal lobes of the brain or the temporal lobes, just like the name says. What can be kind of interesting about these is that they can actually be unilateral. So you can have a frontotemporal dementia that just affects the left side of the brain and not the right. And you can actually see that atrophy occur on an MRI where there'll be just the left temporal lobe is atrophic and everything else is fine. You know, the understanding as to why would it be unilateral, why are certain lobes affected over others, are questions that we don't have very well understood. One of the ways this can manifest actually is with a symptom complex where people can't talk. We call that primary progressive aphasia, or PPA, where people will first have difficulty speaking, their speech gets worse and worse and worse, and then later on, after the speech is degraded, then they begin having other cognitive issues like short-term memory problems and stuff like this. So it can be a particularly frustrating thing to deal with as a family and as a patient, for sure. So if we look at this, I like this picture because it really gives, you know, the notion, right? Which is people it's very confusing. You know, well, how is Alzheimer's and dementia, how are they related? And so dementia is really the umbrella term, right? It covers everything. And it's any situation, any condition that's acquired where you lose your cognitive function. Far and away the most common cause of dementia is Alzheimer's, but certainly we see these other causes as something that is becoming more and more common. And it's, yeah, okay, I'll leave it at that. You know, you know, as we talk about, you know, treatments, really at the end of the day, as things stand right now, the treatment for all of these is very, very similar. Although I'll be focusing on Alzheimer's disease. So Alzheimer's disease is a specific entity. Like I said, 75% of all dementia, so the vast majority we think. And this leads to about 5.5 million folks in the US right currently with Alzheimer's disease. But we see this oncoming, you know, increase, right? And the term that we've used is, and this is, you know, this is trying to make fun of it, but this is a big deal, which is this silver tsunami. These baby boomers who are coming at us, who are getting to the age of 60, 65, 70, 75, 80, where we're seeing, you know, we're going to see the rates of dementia across the board. And you know, the concern is, can we handle this? And if we look at the percentage change of, you know, of dementia, you know, this was 2016 data projected that we're seeing come to real life. A 15% increase in the state of Arizona from 2016 to 2020, and a more than 50% increase by 2025, just from the aging of the population. And the concerns, of course, are, do we have the infrastructure to handle this? You know, do we have the caregivers that are capable of handling this? And the answer, if you ask most primary care docs and neurologists, is, you know, we don't. You know, this is, I feel like this talk sometimes, and I gave a version of this talk a few years ago, I feel like it's a scare tactic. And I wish I didn't have to sound like that. And I'm not trying to scare everybody, but I want people to realize the state of where we're at, which is, you know, this is sort of like COVID, right? COVID hit and we talked about it and talked about it and talked about it. And then it hit and we weren't really ready for it. And I guess, how can you be perfectly? And this is the problem we're going to be seeing, I think, with dementia, unless something changes drastically. And this stems from a variety of issues, one of which is there aren't enough neurologists graduating from residency to fill the need. So my field is feeling it hugely. I mean, we're looking at recruiting neurologists in Tucson since the day I arrived. And it is hard to recruit a neurologist because, you know, everybody's having a hard time recruiting neurologists. And so when the need is there, you've got places all over the country paying ridiculous amounts of money to bring the neurologist in that they can't possibly justify. You know, they get a cherry pick where they want to go, and it's hard to compete in that market. It just is. And so we have this glut coming, and we're gonna have to figure out how to deal with it. And a lot of this falls on the primary care docs. And a lot of this, the majority of this falls on families, right? We have 16 million Americans who provide unpaid care for people with Alzheimer's or other dementias. So this is husbands, these are wives, these are children. And this is, you know, an estimated $244 billion per year of hours that are spent, away from their jobs, away from their family, doing up, taking care of these patients. And again, that's as things stand now. If we look at in 2020, we estimate that, of course, we don't have the numbers yet for 2020, but it's estimated about $305 billion. And in the years to come, it's gonna get more, 1.1 trillion. So scare tactics and things for us to be thinking about, as we look at how healthcare, how we attack this. I don't know that I have the answer. I think that we need more primary care docs. We need more neurologists. We need more caregivers. We have to have ways to be able to handle these. We're just not set up to be able to do this a lot of the times. I had the personal experience of having my own family, and trying to get, into assisted living or nursing care, and through, Arizona long-term care insurance, Altex. You basically have to be non-functioning. You can't get to the bathroom before you're bad enough to qualify, which is, if you're that bad, you probably needed it a long time before. So issues. The other interesting kind of factor is, in all of this, we're seeing this sort of, we're seeing the death toll rise from Alzheimer's disease. We're seeing these numbers go up. When I graduated from residency 13 years ago, this wasn't even on our radar as a cause of death. And that we've seen this now sort of rise to become, the nationally leading cause of death in the United States. In the state of Arizona, it's the 5th leading cause of death. And you can see, right, where things, we've had all this, aggressive treatment for heart disease, and albeit heart disease, cardiovascular disease, which includes stroke, is the #1 cause of death, hands down, and that's where we need to put a lot of effort. But we see an 8% drop in heart disease death and 150% almost increase in the death rate from Alzheimer's disease. We've got a lot of work to do there. And I'm afraid, my story doesn't get better as we go along. Of the top 10 causes of death out there, this is the only one without a really clear-cut prevention strategy. We'll talk about prevention at the end of this talk, and there are certainly things that we want people to do, but it's not perfect by any stretch. And so, and we'll talk about, this is predicated on partly, well, you can't have a prevention strategy until you know what the bloody heck is causing the disease. This is out of the top 10 causes, the only one without a cure, or a clear-cut way to slow progression. So I feel bad because I think this is scary stuff to have to say out loud and to share, but I think this is the truth, and this is where we're at currently with this disease. So to have a cure or a way to slow progression or an effective way to prevent the disease, I think you first have to start with, well, what causes dementia? What causes Alzheimer's disease? And so I'll start with, this is sort of where I look back on my time as a neurologist. I mean, I came out of residency, and this was the golden age of neuroscience, the 80s and 90s, and early 2000s. We identified so many things. We had the treatment for stroke, and epilepsy treatment was improving so much. We were finding effective treatments for Parkinson's disease, and we thought we were on the verge of an Alzheimer's explanation and treatment. And at least so far, that hasn't been the case. And probably one of the most heartbreaking parts of what I've had to do is be a part of that. And so when we look at the causes, we don't know what the causes of dementia and specifically Alzheimer's, but here's sort of at least the state of where some of the things are at. So far and away, the leading explanation has been amyloid. Amyloid protein is what causes Alzheimer's disease. This is a protein that we all have in our brain. We all have something called amyloid precursor protein. It's secreted on our neurons, and it is something that we think it does have a function. The problem is when it gets abnormally processed in the brain, we run into issues. And so this is a picture from the New England Journal of Medicine. And so what you have here is the cell membrane of a typical neuron, okay? And what you have here is the amyloid precursor protein, where right here in this little sort of red thing is the amyloid beta protein. And then you have this other parts of the protein that stick up out of the cell. And so when the amyloid precursor protein gets abnormally processed, you have this amyloid beta peptide. And so what we see is there are two specific enzymes. One's called beta secretase and one's called gamma secretase. And so what they do is they cleave this in just the right spot that this A beta protein becomes free. And when it's free, it tends to want to form aggregates. And those aggregates are a problem. They form these essentially small groups, oligomers, and then those oligomers group into bigger plaques, and those plaques get deposited around neurons, around the cell body of the neuron, the dendrites of the neurons. This is right where the neuron wants to communicate, right? So if this is a typical neuron, and then keep in mind, right, you have 100 billion of them in your brain. And so there's the cell body, an impulse comes through the neuron, it then generates an action potential, this electrical signal that fires down the axon, or these long processes that are going from your brain down your spinal cord to your arms and your legs, but also crossing your brain in a million different places that allow you to see and think, talk. So it comes down to the end here, which is the end of the cell, which I'm blanking on the name, the terminus, the terminal, and you have a synapse where you're going to connect to another cell. And this dendrite right here, this is a connection where the cell will fire off, it will release neurotransmitter when it's activated. That neurotransmitter activates the next cell along, and the impulse propagates. So the problem is those neuritic plaques land in these areas, and they inhibit the ability to propagate information. They actually are toxic to the cells in these areas, causing these dendrites to regress and pull back, which is a huge problem, one, for propagating new information, or to propagating information. The other part is how you learn is by growing these synapses. It's actually really neat. When I was at Columbia, my neuroscience professor, this guy Eric Kandel, goofy guy who wore this big red bow tie every time, he actually won the Nobel Prize when I was there. And he won the Nobel Prize because he studied this sea slug. And the sea slug was really great because it had a very, very, very simple nervous system. And he was able to figure out how the sea slug learned. And basically he was able to show pictures of the neurons. You can't see my hands. The neurons would literally grow new processes. And a memory is created when new processes grow out, a new synapse is formed, and a new connection is made. And by repeating that activity, you make more and more synapses, you grow more and more connections, and that memory gets stronger and stronger and stronger. And so it is a huge problem when these neuritic plaques start to develop and impair your ability to not only propagate information, but also make new memories, grow new synapses. So that's the process that was taught to me, and that's the process still that we think is a leading explanation, but certainly not the only one. So we'll come back to that. There is another group of neurologists, of neuroscientists, who believe that a protein called tau is the real explanation. And one of my colleagues loves to make jokes about they're Taoists. These are the neuroscientists, the cognitive neurologists who think that tau is the major underlying cause of what's going on with dementia. And so with tau, so here's another picture of a healthy neuron. I love these pictures. I think they're just so cool. But so you have a healthy neuron, and again, you have the axon. And Inside the axon, if you were to take a little piece of that and blow it up, you have these highways, these microtubules inside the axon. And so the way that you send information down the axon is sort of twofold. One is there's what's called an action potential and essentially an electrical current that moves down your neuron. But the other way is you actually have to transport amino acids, neurotransmitters, actually the building blocks of the things that your neurons have to do to either grow or to release neurotransmitters. And these microtubules are the way that you transport that information. Those are the superhighway of your neuron of the axon. And these microtubules are basically connected by tau. Tau is the protein that connects the different parts of the microtubule that keep it together functioning. And so what you see, oh, and I made it even bigger picture. And so you see this microtubule coming down, and the components of the microtubule are held together by tau that essentially bind it, the glue that hold it all together. So what you see in Alzheimer's disease are something called neuritic, so not neuritic plaques, you see neurofibrillary tangles. And neurofibrillary tangles are areas of high tau content. And what we see is you get tau becomes hyperphosphorylated, and we don't fully understand why. And when it becomes hyperphosphorylated, it falls off of the microtubule. And so it no longer works as that glue to bind the microtubule together, and the microtubule starts to fall apart. If that falls apart, the neuron itself can't send information down the axon, and the neuron itself gets diseased. And so it disrupts transport of information down that. And so here, this is my simple, but what I like neuron, picture. And you can see, so, we also have problem within the axon itself, and the microtubules aren't working. And so you can't send the information down. That seems to be certainly a possible explanation. So what is it? Is it amyloid beta that's the underlying cause for the problem? Is it the hyperphosphorylated tau that's the underlying cause for the problem? The answer is really not clear. And then to make things even more complicated, there are other things that are going on. There's this sort of role of inflammation that seems to be, maybe more and more important, although again, the jury's out. And so with the sort of some of the data that supports inflammation as an underlying cause is what we see with glial cells. Glial cells are the cells that are green here. So the red are axons and neuron projections that you can see. And the green cells are these glial cells. Glial cells are immune cells of the brain, and they work generally, we think, in sort of harmony with the neurons, cleaning up debris, keeping the environment optimal for neurons to function. And so what we see in Alzheimer's patients is that those glial cells look like maybe they've been switched from supportive to harmful, and they're adding to the toxic environment for the neurons. And at least in a mouse model, when you take out the glial cells altogether, you cause other problems, but those rats can't get, or those mice can't get Alzheimer's disease. So what role does inflammation play in all of this? We don't know. Is it, it's out there as something, and certainly research is sort of ongoing to try to better define this. Beyond that, we've got the sort of the connection with vascular disease, right? And if you pull up, you go to any place and look at, the things that are at least risk factors for Alzheimer's disease and dementia as a whole, half of them are the vascular disease risk factors: exercise, blood pressure, smoking, depending on which ones you look at, obesity, hyperlipidemia. These are all things that seem to be risk factors for causing dementia. And so how prominent is the vascular component? Is it, there seems to be probably a crossover between Alzheimer's disease and vascular disease, and the vascular component seems to accelerate the other neurodegenerative processes, but that's still not something fully worked out. And then what other causes are going to be? What else is there out there? I mean, there's all of these sort of rumors of things that, are in the pipelines that I think are interesting. There's a group out of Harvard that is looking at specifically recurrent infection as recurrent subclinical infection as a cause for this, and postulating that the amyloid protein is part of our innate immune system, and that as recurrent infections occur, that might be what's driving the accumulation of amyloid, and that really those patients who are getting sick are ones with a little bit of a leaky blood-brain barrier, and the blood-brain barrier leakiness is allowing these mild infections, maybe from even dental flora, getting into the brain, and that's driving this. The jury's out, and we simply don't know the answer yet. And I'll come back to this, but I guess I'll sort of touch on it now, which is, the notion has been that this is amyloid, okay? And that's been born out of the fact that we've got that sort of defined better. We can see certainly genetic cohorts of people with amyloid dysfunction genetically are predisposed to Alzheimer's in a big, big, big way. What's caught everyone to pause is that the amyloid treatments that we've done so far, and this is where I think it's been just most heartbreaking for me, where we thought we're on the verge of the biggest breakthrough, this is gonna be huge, have been a frustrating failure. All of these immunoglobulin trials where we've actually got antibodies that bind to amyloid and will literally pull amyloid out of your brain. Those studies, and we know that they're effective at doing that, those studies have not shown a benefit for Alzheimer's disease. And so it's led everyone to sort of say, well, shoot, is amyloid the underlying issue or not? And we'll come back to that in a minute, okay? So the next thing I just want to bring up is sort of the notion of get evaluated, and what's involved in getting evaluated for dementia, for Alzheimer's. And certainly I want people, even though what I'm singing is a pretty bleak story, and I don't do it to be terrible, and I feel terrible talking about it, but I think it is important to get evaluated and assessed for Alzheimer's. And so, oh shoot, hold on here, I want to go, and so what happens when you get evaluated for Alzheimer's? You come in for a doctor's visit, what's going to happen? So the first thing that you're going to get is you should get a good medical history. I want to hear the story of what's going on. I want to hear when it started. I want to know, and to get evaluated effectively for dementia, you really need someone with you. You want sort of a two-person story, and the issue, which is an issue of neurological disease across the board, right? From my perspective, when the organ in charge of knowing what the bloody heck is going on, if that's the organ that's not working right, then we really need someone to help with the story, because you may not fully appreciate what's going on. The brain can't, there's all kinds of ways the brain doesn't realize what's happening to itself. And so the story that we're looking for is this insidious, slow onset, something that didn't happen overnight, that progresses over months or usually, many months or years. And we're looking at disruption of cognitive function. Now, I would sort of throw out there that sometimes it can feel sudden to families. And the way that at least I look at this is, when you love somebody, and this is most true in husbands and wives, but I see this in kids, children of patients, where you're around them all the time. When they make a mistake, you begin filling in their gaps without even thinking twice. And it becomes just part of life that you don't even realize how much you're making up for them until they can't, until they get to a point where it slaps you in the face, they can't function at all. And then the perception by everybody is that they were fine until all of a sudden they weren't. And it's sort of that sort of, I guess, notion of you're a foot from the cliff, you're an inch from the cliff, it feels about the same until you fall over that cliff. And that's sort of the notion that sometimes we'll see with cognitive disorder, but almost always we get, that sort of that history of other issues that have been going on longer. And often we're looking at memory loss that disrupts daily life. Okay, I mean, we all forget names and places, and the example I always give to people is, as you get older, that file cabinet of names and places and people is just bigger and bigger and bigger, and finding the right file, the right drawer is just harder to do. And usually it comes back to you when you stop stressing over it. But if we're having memory problems that seem to be a recurring issue that disrupt your life, you lose things and you just can't find them over and over and over again, that becomes something that becomes a little bit more concerning. I would sort of point out, the absent-minded professor that's always been absent-minded their whole lives, I'm not so worried about. The ones I'm caring about here are going to be the change. Misplacing things and losing the ability to retrace steps. Again, I mean, I think that I will point out that the most common cause for these first two issues that I see when people, first of all, I point out when people come to me worried about forgetting stuff and those are their major issues, I'm almost immediately reassured. And I sort of point out that often with Alzheimer's disease and dementia, the people that have the issues are the least aware of what's going on. So they're not, they're finding some excuse for it all the time. And the ones that are most worried about it are usually the ones who are just fine. But the most common thing that I see that's causing these things is simply just too much going on. You're multitasking, there's too much going on, your brain is thinking about something else, and you're not paying attention to the here and now, and when you don't attend, you don't remember. And so that, I always think, bringing my kids home and they're screaming at me to do this, do that, and I throw my keys down and run into the house, and then 2 hours later try to figure out where I left my keys and I can't find them. That's normal. But when this becomes a recurrent issue and you really can't kind of figure out where they're at, that's where I start to get worried. Challenges in planning or solving problems. This is this sort of goes in line with not being able to figure out things that you should know how to do. Playing a familiar game, a familiar task that you know how to do. I think 3 and 4 sort of go hand in hand. People will have problems paying bills. Often I'll ask, well, who's paid the bills in the house? And has that changed over time? Oh yeah, we had to stop doing it because he was making mistakes. Who does the grocery shopping, generating the grocery list and planning meals? Who's doing that? And has that changed at all? Confusion with time and place, getting mixed up where to go, a familiar place to drive, getting lost, forgetting where you're at. We all forget the day of the week, especially when you retire and you're not paying attention to the days. I don't get too worked up over that. Is it the first? Is it the second? But getting mixed up on the year, where you're at. One of the things that I see is that, people will, especially when they're tired and worn out or they're sick, think that they're back at work, think that they're at a different location, they're at their, a place they lived in the past. Those are things that are certainly red flags for me. People can develop problems with speaking and writing. I've certainly had that with Alzheimer's disease, although we see it more often with the frontotemporal dementias. Poor judgment in things that you do. Withdrawal from work or social activity. I'd point out this is a hallmark of a dementia mimic, which is severe depression. But certainly we can see as the frontal lobes get involved, changes in personality, changes in the way people behave. Someone who is outgoing just becomes withdrawn. Someone who is fastidious about how they looked becomes a little bit sloppy, doesn't shave. I don't know if you can see me, I didn't shave, but I've always been sloppy. And then changes in personality and mood. I think those go hand in hand. So those are the things I'm sort of looking for, and the doctor will be looking at issues. So getting a good medical history, also wanting to know diet, nutrition, alcohol consumption. Alcohol, as much as I love to have a glass of red wine, I'm more and more of the opinion that alcohol is a net negative for the brain. Maybe red wine has the positive effect of resveratrol and antioxidants. But I think that certainly overconsumption of alcohol is negative for the brain. Medication list is going to be crucial for my end. Looking at, one of the most common causes of cognitive impairment that we see is polypharmacy. And I throw out there, so like what types of drugs would do that? You certainly see that effect with antihistamines. Benadryl, for instance, is an anticholinergic. It binds, it blocks the neurotransmitter involved in memory. Anticholinergics are a big one, antihistamines. Many of the pain medications, opioids, anti-anxiety medications, benzodiazepines, sleep medications, those are all things that we want to be in tune with and certainly have the risk of causing cognitive issues. And then, we'll do some type of cognitive assessment in the office. One is the mini mental status exam. You guys may have seen this in the past. The MOCA exam, which is the Montreal Cognitive Assessment Exam, which is what Dr. Trump, oh my goodness, Donald Trump aced. He's able to name a lion, a rhino, and a camel, which I'm glad that my president could do. But these are the things that they'll ask you to do. And they're just a general sense of, you can see, looking at visual spatial skills, your naming, your memory, attention, which is a big one. And these are general gestalts. These are not the most sensitive tests in the world, but they help get us an idea. If we go beyond this, usually people get sent for neuropsychological evaluation. These are tests that get done in 10 minutes. A neuropsych exam, which is a very in-depth test of cognitive function, takes a full day. And it's all of these types of tests to the nth degree. And often other testing that we'll do, sleep studies, depression screening, looking at other causes of cognitive impairment. We're looking at things that we can treat, right? Looking at thyroid function, liver disease, kidney function, B12 levels, folate levels, vitamin D levels, all things that we know when they're off certainly have a negative impact on cognitive function and things that we can treat. And then of course, brain imaging. And so the classic brain imaging that we look for, this is an MRI of someone with sort of your classic dementia picture, right? And so what you see here is a normal brain. And the arrow is pointing to the hippocampus, which is you have this little slit up here, which is a little fluid-filled space called a ventricle that wraps around here. And this hippocampus is there. This is the place where new memories are made. This is the first place that we tend to see atrophy in Alzheimer's disease. And so what you see in someone with Alzheimer's classically is this progression, normal, and then you get some atrophy, particularly pronounced in the hippocampus, but you see it in other areas of the brain. And then it becomes quite pronounced later on where remember this slit that was there before is now a rather big area of fluid because now there's simply just less brain there. Now I would point out, we see that pattern on an MRI very, very infrequently. We don't see that very often. And so more often you're getting scans for cognitive impairment, mostly to look for other causes. Am I seeing accumulated vascular disease, in which case I'm really worried about your stroke risk factors? Or is there something else? And this is a picture, an MRI of someone, and this is something called a subdural hematoma. This is blood or fluid that's accumulated over this patient's right hemisphere. And this is something that can happen after trauma. He's actually got a big goose egg on this side, so this person fell and hit their head. But this can happen after mild trauma. And the trick is with these types of bleeds, they happen really slowly. These are venous bleeds, this low venous pressure that can accumulate slowly over time. And it doesn't necessarily cause your classic terrible headache or sudden weakness on one side. Sometimes the issues are slowing of cognitive function, and that's the type of thing that we're looking for that we can maybe intervene on. So when we come to current treatment, the landscape in my mind is frustratingly not great. The medications we have, which, there's a drug called donepezil or Aricept, memantine or Namenda. There's a combo medication that have the two. There's a few other acetylcholine drugs that essentially increase the amount of acetylcholine in the brain. Exelon, which comes as a patch, and galantamine or razidine, which is another pill. These work to increase the amount of acetylcholine in the brain. That helps symptomatically in some patients. None of these address the underlying cause of the disease or the process. So I think that they're fine, although I always tell my patients, or at least when I was in clinic, told the patients that if there isn't a real benefit, if you don't feel like you're getting help, and I would point out, this is a question that I always aim at the patient and their family. If there isn't a clear improvement, you don't think you're better on the medication, then I'm not sure that it's really doing a whole heck of a lot beneficial for you. But if you feel better, then take it. If it's helping with cognitive function, and certainly some patients do respond, stay on it. But I go back to the frustration of this is our only top 10 cause of death without a clear prevention, cure, or slowing progression approach. And this leaves us all in such a big lurch and frustrated. And of course, the patients with, what do I do, doc? What the heck do I do? And so, one, I sort of reaffirm to everybody here, patients should get evaluated, okay? I think that the nihilistic approach would be, oh, why bother even getting evaluated? If there's nothing you can do, why bother? So one, okay, fine, we should get evaluated and get you diagnosed, because if we can initiate a treatment that gives you some benefit, we should do that. And albeit that's not the majority of patients, but it's an important number of patients who really feel value and benefit in that, we want to do that. Number two, we can define an alternate cause that sometimes we can treat. Okay, that subdural hematoma, I can treat. If there's something going on, if there's sleep, if there's severe depression, I can treat that. If there's severe sleep apnea, and that's part of the picture of what's going on, I can treat that. If there's thyroid dysfunction, I can do that. So there are treatments out there for some of these alternate causes. And then I think it's important, the mantra from the Alzheimer's Association is the first survivor of Alzheimer's disease is out there, right? There's a treatment. We will find a treatment. I mean, the government, the NIH, I mean, people have heard the call of the condition that we're in. The amount of funding that's going into research is growing hugely. And so getting folks diagnosed so that we can get them enrolled in a clinical trial is certainly, I think, a huge, huge deal. And then lastly, I think that, a diagnosis is important to be able to plan for the future. I think that that's an important part of this disease. And so being able to think about how we're going to handle that loved one and what their wishes are, so that when they can't communicate that in the future, that's something that we upheld. So new treatments. I think that, so it's been a gut blow to everybody involved, in the sense that, the treatments that we've had haven't been effective. And so, and this is sort of highlighted in this, another, not great picture, right? Which is between 2002 and 2013. And I'd point out, if you branch this out to 2020, the numbers go up, the results look about the same, which is, the number of benefit, studies that have shown, benefit is tiny compared to the number of studies that have been done. If you look at the cancer studies, it looks incredibly impressive compared to what Alzheimer's studies have looked like. And so we've really felt, this ache of not being able to get where we want to. And so why? Well, we don't know, okay? Part of this may be that the underlying process is not right. There's a definite group that feel that the part of the issue has been that this is a disease that has a very long preclinical phase, and that this preclinical phase is the key spot to be able to intervene on, or at least earlier in the disease process, right? And so, I mean, what we're seeing is that we're intervening here, or maybe here, but we need to be intervening here, or somewhere back in here. And that's sort of at least some of our hope with some of the studies that are going on right now. And so then the question becomes, well, do we have the capability of identifying patients earlier? And their answer is, we do. Part of this is, and it's the different types of techniques that we have to help support the diagnosis. MRI is one, and there is sort of this growing data of volumetric. We can measure the hippocampus on an MRI. Radiology Limited has a really good program set that they have, where they try to measure the volume of the hippocampus. and that can be useful in supporting the diagnosis of dementia, albeit I don't think that one's perfect still.
Dr. Teeple, we have just a few minutes left.
Okay, PET scans are another one that's sort of out there, although I think that that's general. The classic PET scan is less useful. Lumbar puncture, and so we'll come back to PET scan in a second. Lumbar puncture is an interesting one. What we found is that in folks with Alzheimer's disease, they drop their levels in the CSF of amyloid beta protein, and their tau protein, as it falls off their microtubules, goes up in the spinal fluid. So we can actually test to see dropping levels of amyloid and increasing levels of tau in the spinal fluid, and that can support the diagnosis of Alzheimer's. And then I think the most important tool that probably we have in the preclinical setting is going to be Amyloid Pet Study. So we can actually do a PET study where we can actually detect the amount of amyloid in the brain, and that has a very strong correlation to Alzheimer's disease. And you can see someone who's normal, and this is the amount of amyloid that is bound. The more red and yellow it is, the more amyloid there is, as opposed to someone who's got Alzheimer's. You can see the big difference that we see. And so what's out there next? And we have trials in early disease and people that we know are genetically predisposed to Alzheimer's disease, passive immunization. So giving them amyloid antibodies and giving it to them every month or every 3 weeks, 4 weeks, 2 weeks, to see if we can passively immunize them, pull out the amyloid, and if that works, and really treat them in that preclinical phase. There are more studies, although one has already come back negative. We are studies in looking at inhibition of cleavage of the amyloid protein with that beta secretase inhibitor that I talked about earlier. There are tau-related therapies out there, immunization for tau and things that we can use to help prevent hyperphosphorylation of tau. Inflammation is going to be a hot topic as we move forward with different drugs out there that can stimulate the immune system, those glial cells we talked about, and that might have impact on it as well. And you can see, I mean, this is just a small, taste of all the different studies and products that are out there. Some of them in phase 3, many of them in phase 2, so they'll be coming to phase 3 into our clinics sometime soon. Some of these even, this one here is an actual, blocks the pathway in how signaling is made inside the cell that causes the cell to respond to amyloid and maybe preventing some of the inflammatory cascade in the cells, essentially blocking something called the Abl kinase, all kinds of novel therapies out there. These are all the different antibodies, and you can see in the different phases of treatment. I'm trying to leave you all with a sign, the message of hope. This is something that, while it's been frustrating and heartbreaking to me, you can sort of sense that in my talk, there is a lot of reason to be hopeful. And I think that a lot of reason to get our patients diagnosed so that as these come into phase 3 studies, we can get our patients enrolled in these clinical trials and get them help. If you're ever looking for anything to do, the Alzheimer's Association has an excellent program called Trial Match. Well, basically you can tell it about yourself, how old you are, what your diagnosis is, how far you're willing to travel, and they'll pair you up with clinical trials that are out there in the community. It is awesome. And certainly trials at our group that are associated with Center for Neurosciences, that's associated with TMC, and Margie Pazzi, and we have Michael Bader-Doja who's running those clinical trials in our group. I know we're out of time. I'm going to leave you with 10 ways to love your brain. Maybe this will slow prevention. Maybe this will help prevent. This is certainly the things that I focus on in my life, and I certainly urge you guys to do it and sort of, paint the picture to all your patients, your family, your friends. Break a sweat. Encourage people to exercise. The best thing you can do for your brain, your heart, your psyche, your soul is to be active. Exercise in any way that you can. If your hips and your knees and your ankles don't let you, swim, stationary bicycle, but do whatever you can. Stay active. Dance. The Udall Center used to have this fantastic senior group that would go out there and dance. I used to have this great article on my wall of one of my patients who was, in one of the pictures that the Arizona Daily Star did. But find something to do, frustratingly, you know, right now in the privacy of your home or socially distanced. Hit the books, do something, challenge your brain, learn something new. The Arizona Extension, I was looking up online, you know, the Rosetta Stone has fantastic language learning software that you can do remotely on your computer. Learn something new as often as you can. You never stop learning. You know, God forbid anyone here smokes, but if anyone you know and love smokes, you know, whack them on the back of the head, do what you can to help them quit. I get it. It's the hardest thing in the world to quit, but no question, bad for your brain. Everything you can do that's good for your heart is good for your brain. You know, the mantra, you know, when I was part of the American Heart, or more involved in the American Heart and Stroke Association, is what's good for the heart is good for the brain. Anything that anyone tells you you do for your heart disease is going to benefit your risk of stroke and dementia. Fuel up right. You know, the more green leafy vegetables, whole grains, dark colored fruits, rich in antioxidants. They talk about cold water fish high in omega-3. We talk about the blueberries, the dark colored fruits that are rich in antioxidants. Those are the things I want you eating. My opinion is that the more plant-based and well-rounded your diet is, probably the better from a stroke, cardiovascular, and dementia standpoint. Make sure you sleep. Isn't that baby so cute? Sleep is so important. Don't forget about it. Take care of your mental health, especially these last year, something we all need to be paying attention to. Good day that says that budding up and being with friends, that having some type of social interaction is good for your brain, is good for your neural connections beyond just the mood boosting benefits. So try to do it. Like I said, stump yourself. I did luminosity last night, or lumosity yesterday, and I did horribly terrible in there. They have one of these, they'll measure you in the beginning. And I did great on 2 of the 3 tests, and I did horrible on one of them. But so, you know, stump yourself, challenge yourself. And with that, I know I'm 1 minute over, but
That's okay. Dr. Teeple, we do have a question in the Q&A, and that's from Mr. Donald Drain. Is dementia more prevalent in men or women, and is there a reason for which one?
You know, it's a good question, and it is probably, so I don't have a perfect answer for that, and I would tell you it is an equal opportunity factor. I think it's out there. If there's a big difference, it's not huge. You know, part of me wants to say women are going to be more because women live longer than men, but on the flip side, the cardiovascular disease profile for men is a little bit worse. So it's a great question. I don't have a perfect answer for that. It's not something that's so profound like we see in heart disease, for instance, in men when they're younger, or in other diseases like migraine or other things where we see a predominance in women. There is no big difference that I see from my end.
I have a question. This is Adeline.
Yeah.
Pima Council on Aging recently got a grant for Alzheimer's Friendly Community. Will you and or TMC be participating in what they are doing, or are you even aware of it?
I think we may have lost Dr. Teeple.
Oh.